Okay, let's get started. So we're going to begin with the second half of bacteriology, and that's where I usually suggest that you can start making your tables and charts. Today we're going to go for 4 bacteria, so you can kind of make a chart for Pseudomonas, Haemophilus, Legionella, and Bordetella. And you will see me talking about some of the similarities and some of the questions that normally are asked. So that's your take. As we are moving along, some of these bacteria are being put in one lecture for a good reason. I'm going to explain that to you in a while. So Pseudomonas, if you remember, as a family is, well, most of the bacteria have very large families, and they can be divided into different kind of classification, as we've been talking earlier. But as a larger group, without going in detail, they have some of the common characteristics. Whenever you see anything say ubiquitous, this means present everywhere. That's pretty much the word stands for. But by far, the most important thing for most of the Pseudomonas are that they go for decaying matter, vegetation, and water. So you can also see that when we have to check for bacterial content of water, we check for Pseudomonas. And they can also be a part of hospital-acquired infection. And that's, again, when I talk of hospital-acquired infection, I'm going to ask you what are the bacteria, what are important bacteria, and some of the decisions that you have to make, or people are going to ask you, they need to make, especially in terms of carrying infection to the hospital, but there's nothing you can do about that. For example, you can see that this particular bacteria wants to go for a moist environment. So what it means is that food, flowers, all these kind of equipments that we have in hospitals where there's dampness, or liquid like dialysis patient, and even disinfectant solutions. So don't go into believing that everything that's disinfectant is going to kill other bacteria. It may itself harbor bacteria. And that actually reminds me of the next lab as well, where you want to make sure that you prepare chapter 3. That's a disinfection chapter. We talk about the chemicals and other things that are there. But by and large, they have a broad environmental distribution. The reason is that if any bacteria has simple growth requirement, for example, if bacteria does just need water, so it's going to grow everywhere, as compared to some bacteria when we say they have fastidious growth requirement. Okay? So they can thrive on media and make their life simple, and so they are basically capable of causing problems. And when we talk about they like to grow on organic sources, that would suggest to you on dead tissue. In this particular case, Pseudomonas infections are notorious for burn wounds. So when we have an open burn wound, we have to be careful. And some of the strains for Pseudomonas can even grow in distilled water. So they will just use the bare minimum nutrients like trace nutrients and still can thrive. So these are some of the characteristics you have to keep in mind. They also have factors like pathogenic factors, like enzymes that would enhance their virulence. And then all the bacteria that we're going to talk about by far are becoming or have become resistant to antibiotics. So that's there. Again, continuing from yesterday's lecture, we talked about commensal bacteria, opportunistic bacteria. So likewise, even if they are present on your body, if the skin is burnt, or if mucous membrane is abrased or damaged, there's always a chance for them to find this opportunity and find a niche to go in. If you look them under the microscope, they, of course, are take gram staining, positive or negative? Negative. So they are gram-negative rods. As you can see, they can appear in single and pairs. And if you were to look at, for example, this is a typical patient. Also keep in mind some of cystic fibrosis patient. So cystic fibrosis patient, and they have this sputum which is very mucoid. So that's the problem with them having respiratory problems because they cannot, they have this ability to form mucoid sputum. So that's where you can see over here it can thrive, and it's a typical sample that we normally see from those patients. This is also a bacteria that's common causing skin infection, and the way it causes infection is typical. We call it heart tub folliculitis. So hair follicles, for example, pinned over here. So they have this distribution over here for the whole body, and sometimes it also appears like a athlete's foot. The only difference in this case is that normally if you've seen athlete's feet or foot, it basically is white. But if it's any other color, the chances are pseudomonas are there, because pseudomonas tend to be very colorful. I already told you about number one culprit in wound infections, number one culprit in especially burn wound infections. Folliculitis, as we saw in the previous figures as well, it may appear as a rash, but there will be usually a history of using hot water or swimming pool, kind of sharing swimming pool with others, like a public swimming pool. Also very nasty bacteria in terms of bed sores. So you can see if these are typical bed sores that develop, very difficult to handle these patients. These are the pressure points when people are there for long-term care, and they're hospitalized or bedridden for extended period of times. Now, as I said earlier, the very special thing for Pseudomonas is that they form pigments. As I gave an example for athlete's foot, instead of whitish, it was bluish. So they have this typical green pigmentation, even if they were to grow on media. So you can see from here, especially Pseudomonas aeruginosa, green pigmentation, and that is basically coming from two water-soluble dyes, blue and yellow. And interestingly, in industrial microbiology, we do have these bacteria producing colors for us. So the color that you see out there, the bacteria are producing for you. So that's an industrial good use of Pseudomonas, other than what I'm going to teach you in terms of disease process. Typical slide that you will see over and over again for each and every bacteria, but I'll just try to emphasize some of the important points. In this case, it is an aerobic respiration. And then again, it has a very important test that we normally do to differentiate between Pseudomonas from the rest of gram-negative rods. So that's a question out there, and it's based upon cytochrome oxidase. So this is a rapid test that we normally do, a cytochrome oxidase test. And we already talked about cystic fibrosis. If you were to ask which one is the most common bacteria found in cystic fibrosis patient, the answer is, of course, Pseudomonas. And as I said earlier, they form characteristic colors. And many times you must have seen very common thing the physician will ask you. If you say, I've got sore throat and I'm passing phlegm, they're going to ask you if it is colored or it is whitish. So if it's like colored, so that basically signifies bacterial infection, not necessarily Pseudomonas. This bacteria are the one that form color. Now, as I said, they are small size, gram-negative, and they can oxidize glucose. We already talked about simple nutrition requirement. They have a very complex mucoid polysaccharide capsule. So the reason is, if you have a very complicated mucoid capsule, you have tons of virulence factors. And all these pretty much will come from the first lecture list that we have. They have an ability to adhere. They have ability to secrete toxins, especially exotoxin A. And then they have some of specific resistance gene. So these are some of the multiple virulence factors they have. The more virulent factors any bacteria has, the more problematic that bacteria is, and this is difficult to treat. We see typical diseases in Pseudomonas as respiratory tract infection, urinary tract infection, skin and soft tissue infections, and even causing bacteremia and endocarditis. It's pretty much, as it's ubiquitous in terms of presence, it can cause disease in any part of the body. For pathogenesis and immunity, again, as we discussed earlier, is that if any bacteria releases a toxin, or any bacteria releases a what do you call a particular virulence factor, our body deals with it in the same way that we've been talking about in the typical pathogenesis and immunology in type 1, type 2, type 3. One of the most important things for these kind of toxins is, I think that was probably physiology, if I believe it correctly, first or second lecture, when we were talking about secretory system, that how do cells secrete. And we talked about, when we talked about osmosis diffusion, at that time there was a very specific system whereby some of the chemical substances are delivered to a cell. So there are type 1, type 2, type 3 secretory system that we call, and especially when we talk of AB toxins. So in this case, the delivery system where a bacteria will inject a toxin into the cell to cause tissue damage is type 3 secretory system. That's the most important thing as far as pathogens is concerned. And remember, in the previous bacteria, we've been talking about the ability of bacteria to form a pore, for example, or to attach to the fibrogen receptor onto the surface, and so on and so forth. So every bacteria that releases a toxin, and that actually is also important for us for drug delivery as well, because if you want to deliver drug into the cell, you want to make sure that it passes through the cell. So you have to find all those ways, as we've been talking about antibiotics, how do we get antibiotics into the system? Okay, now as far as epidemiology is concerned, I already talked about that. They also have an ability to transiently colonize. So in the hospitalized patient, there's always a risk over there, and they want to make sure that they have proper cleansing of their respiratory equipment or any other equipment that has water supply, for example, refrigeration or air conditioning, for example. So these are routinely checked for Pseudomonas. So if you ever go and visit hospital and you want to look at the FDA kind of checklist, you will see that they have been tested for Pseudomonas. How do we diagnose them for patient? Pretty much based upon the test that we have, growing them on agar plate. They have the ability to form a very colorful, especially green pigment that I showed you earlier. They also have an odor. Remember I told you earlier that the odor is coming from bacteria. So once you have the lab next week, don't try to kind of smell for the odor. So what's the danger if you do that, if you want to smell the bacteria? Yeah, if they form spores, but they're gonna go to your nasal cavity anyway. If you smell them, you got it. It's just like one of the stores I saw that if you break it, you bought it. This was probably cutlery or very delicate store. It says if you break it, you bought it. So that's what, if you smell it, you got it. So it has beta hemolysis. We do simple biochemical tests. They have ability to oxidase selection. They form oxidative utilization of carbohydrate. That's pretty much where the smell is coming up when they ferment different carbohydrates. As far as infections are concerned, regardless of, I mean, I'm not going to teach you pneumonia because you will pretty much know what are the signs and symptoms of pneumonia. But what you need to know for any particular bacteria at this stage is that they have ability to cause pulmonary infection, skin infection, urinary tract infection. Yeah, so these are very common bacterial infections that you can see me talking about, right? It's very easy for me to show this slide, but what will happen is that, for example, the way the questions are designed, which of the following bacteria can cause bacteremia? So you can see very few bacteria will cause bacteremia because that shows that these bacteria have an ability of virulence vector to go into the blood. That's why they have involvement of a lot of different systems, because anything that goes to the blood is going to spread. Okay, how do you treat? Again, the treatment of choice are aminoglycoside, beta-lactam antibiotics. And then again, we really have to, for prevention, hospital infection, and all those things that we normally use in the hospital have to be decontaminated at all times. The other important thing when I talk about the size, I want you to kind of have this feeling that if the particular bacteria is airborne, right? And the way our respiratory system is designed, they're here in the upper nose, and they're cilia in the lower part. So that's a system over here with many of the dust or the mucus present over here will trap the bacteria. It depends upon their size as well. So the particle size deposition in our whole system varies. So we have nose and throat, upper respiratory, lung, and gas exchange. So as you can see from 1 to 4, as we move along, gas exchange area, if you remember what is the size of that membrane, I'm not going to ask you, but this is something we need to know for blood-brain barrier, for kidney barrier, glomerulus, for lungs. What are the membranes that form those barriers, and what is their size? Because this is going to get inflamed, and it will increase in size. The diffusion of gases will be different. That's what you studied in respiratory physiology. Okay, so in this case, again, if it happens to be a bigger size, more than 10 micrometer, then it's going to be trapped over here. And then you can see the smallest size microorganism is going to cause problem when there is the smallest diameter or radius available for these to penetrate. So that's the whole idea for gram-negative rods causing respiratory infections. So there's a good reason for them to go and cause problems. So when we talk of gram-negative rods of respiratory system, those of you who are confused where this lecture is, I did post as a PDF this morning. It should be there in the Moodle, but they're also scattered in 2 lectures if you want to go for PowerPoints. So it's there in the PDF, I think lecture 11A. So when somebody's going to say in the hospital, gram-negative rods of respiratory system. So now we are a little bit to the systemic thing, right? As compared to gram-positive bacteria or gram-negative bacteria. So we will immediately think of Haemophilus, Legionella, and Bordetella. So these are the 3 important bacteria when you talk of respiratory system. Let's begin with the Haemophilus influenzae. And that's where I want you to make sure that you don't confuse that Haemophilus influenza bacteria with virus. One is a bacteria, when it's called Haemophilus, influenza virus is going to come. Okay, so that's very common added distractor in virology or bacteriology. So pay attention to that. These are gram-negative rods, but some of the rods that you saw in those gram staining, some of them become old. Some of them don't take the stain right. They appear as if they may be pleomorphic. So they may come in different shape, like coccobacilli. They are facultative anaerobe, they ferment. The most important thing for this particular Haemophilus is, which I'm going to ask you, that they have 2 virulence factors, factor X and V. So that is required for the growth. Okay. If you were to divide them serologically, they are type A to F, but if you divide them on biochemically, they are different types. So you don't need to remember the types, but you need to know that there are different types of bacteria. The only thing that you need to know from any type from A to F is H. influenza type B. This is the most virulent because it has polyribitol phosphate in the capsule. So that's the question over there always asked when you are asked about Haemophilus. There is one chemical structure which is PRP, polyribitol phosphate, and that is HIB. We also say HIB. So if you see HIB, not HIV, pay attention to that. This means Haemophilus influenza type B. What does GAS stand for? GAS. Overwhelmed with statistics. Group A streptococci. I say group A streptococci. Anyway, so Haemophilus adhere to the host cells via pillar and non-pillar structure, because if they have to, also keep in mind, especially gram-negative rods of respiratory system when you're respiring all the time. But this means they have to be sticky to stay over there. They have to have those pathogenous factors to go and attach there. Okay, and why influenza is important, because especially it is very common in infection in pediatric patient, but now we do have a vaccine to give to the kids, which is called HIB. That's what I told you earlier, influenza type B vaccine. So don't confuse that. Don't ask me, oh, is it a typo there? There's no typo there. It's meant to be HIB. Okay. In the previous slide, I didn't mention, but I said larger family, there are more than 200 different types of Haemophilus. But we basically, in clinical setting, talk of 3. And that's the term we want to use, a differential diagnosis. You know, if you see a disease, you want to find out which of those particular bacteria has a higher incidence of causing a disease. So if you were to compare Haemophilus, keep in mind, there is another bacteria which is Haemophilus parainfluenza. That's different, right? But it is the most common species in the mouth that we have as a normal commensal, but it's rarely pathogenic, right? But it can become opportunistic if you have a ulcer in the mouth, if you have injury in the mouth, or so on and so forth, okay? So that's the difference between Haemophilus influenzae and parainfluenzae. Keep in mind also there are 2 viruses which are influenza and parainfluenza. They're going to come later. Now, the other important thing is that when a person comes with infection of the eye, the most important cause is Haemophilus aegyptius. So that's the very common cause of purulent, mean pus-forming conjunctivitis. That's inflammation of the eye. And lastly, when I'm going to talk about syphilis, or I'm going to talk about STDs, I'll talk about, because the other day, what was the key word I told you when I talked about gonorrhea? How would the gonorrhea patient present in STD? How would asymptomatic people present in the clinic? He's asymptomatic, it's not going to bother. Urethritis, but I will use the word drips. That's a typical presentation of a person presented in drips. That's what they call, right? The other term in STD clinic, they talk of ulcer. So this is unhealing ulcer that's present on male and female genitalia that brings them to STD clinic. So we will talk about that. We'll call that, we'll show you when we talk, it's going to call chancre or canker, both words are used. But in this case, if you were to look at differential diagnosis, that how would a person have a ulcer on the glans penis, for example, if a male presents? It could be, of course, it's an STD, it's serious, but at the same time, it could be soft chancre or canker, right? In that case, Haemophilus ducreyi. So Haemophilus ducreyi will be a culprit as well in differential diagnosis. Okay, so that's the important thing. Or Shankarite means Shankar-like, like toxide, toxic-like. You know, that kind of word that we normally use in terms of that. Now, the three important bacteria, as I said, Aegyptius, very important for conjunctivitis, but can also cause purpuric fever. Ducreyi, as I told you again, is very important for genitals and also the lymph nodes involved. When it comes to influenza, that's where we have a problem. That's why we vaccinate the kids with HIV because of meningitis. This is also important cause of meningitis, other than streptococci pneumonia. Okay. Then it has, you can see over here, otitis infection, and we have sinusitis, epiglottitis, tracheobronchitis, bacteremia, and pneumonia. So you can see because of a lot of multiple factors, because of complexity of the capsule, it has an ability to cause disease. So it's serious, Haemophilus influenza in terms of diseases. Okay. Okay. As I said earlier, I would want you to know for Haemophilus, growth stimulating factor, which are called X and V. X stand for hemin, and V stands for it stands for vitamin, but basically it's nicotinamide adenine dinucleotide. So these are the two important things that basically are a growth stimulating factor for this bacteria. And if I was to grow this bacteria on a culture as compared to Pseudomonas, that's what I want you to compare all the four bacteria. Pseudomonas was as a simple requirement, it's going to grow with trace element. But if I want to grow a Haemophilus, I need to, number one, use blood agar. Not only blood agar, but we need to add these two structures into the growth factors into that. If you do not add it, then we have a problem. So this is where the term in bacteriology, when we say blood agar, there's a blood in agar, but if you boil that, we call it chocolate agar. So heated blood, when used for bacteria in microbiology, is called chocolate agar, and that's basically used for isolation of Haemophilus. So if you were to separate it out, you're going to plate it out on chocolate agar, and you're going to put all those sensitivity bacterial discs that you will do when you come for the next lab. So this is important for you to know in terms of Haemophilus. Staining, as you can see, Haemophilus influenza, coccobacilli in patient with pneumonia, and then again, it's a thin pleomorphic in an unvaccinated child. It says in Africa, because he presented in overwhelming meningitis. Before HIV, we had a very high incidence of meningitis. Okay. All right. I don't know why did I put it over there, but you can see these are cells, and these are tiny little gram-negative rods. They're trying to get into the cells. Copyrighted material. Okay. Now, we already talked about the cell wall, complicated cell wall structure. In this case, I want you to pay attention that it has LPS, lipopolysaccharide, right, with endotoxin activity. And if you look at the polysaccharide capsule, there are 6 antigenic serotype A to F, and we have just developed one vaccine against type B. But the good thing is we found out that we basically, if you introduce only one B type serotype as a vaccine, you pretty much take care of 95% of the disease. Okay, but also keep in mind that there was a time before we had vaccine, disease was basically very common in the child, and now after the advent of disease vaccine, we have taken care of it. But now there's another problem. You know, other than bacterial resistance, we have another problem that now what we see in epidemiology is that half of the person who will have meningitis will have a non-encapsulated strain. So why is it say non-typable? Why is a non-encapsulated strain of Haemophilus non-typable strain? It's a basic immunology. Are you with me? Yeah. What was the question? For record purposes, because everything is recorded. When you woke up, I said, why is a non-encapsulated strain of Haemophilus non-typable? Yeah. Why? Okay, why? Yeah. Say it again? Yeah, because they don't have a capsule. If there's no capsule, there's no antigen. So you do this type based upon the antigen. If you don't have a capsule, if you don't have an antigen, how can you type it? It's non-typable. And then again, reasoning because there's no capsule there. Is that the point? Okay, you were thinking correctly, but maybe not finding the right word as compared to quite other of you who are just overwhelmed with stats. Okay, so you can see from here, this is a bacteria, and I say very complicated. It has a type B polysaccharide, especially this one, which I told you, the PRP, which is polyribositol phosphatase. So this is kind of important in terms of this attachment. So that's important for you to know as compared to any other bacteria. We already talked about that. Since we have this vaccine, which is a conjugated vaccine, we pretty much are taking care of most of the cases that we have. But if we don't give this vaccine, Haemophilus influenza H1B, or a person is non-immune, as you saw in the 1-year-old child in Africa, then you may be susceptible to all these diseases. Okay. For pathogenesis, both Haemophilus influenza, parainfluenza, even non-encapsulated H. influenzae colonize in upper respiratory tract, and then they can either cause spread from upper respiratory tract, they can go to the ears and eyes, or go down. So that's like physical kind of spread locally, but they can be absorbed in the blood and cause a disseminated disease, especially in unvaccinated children, causing meningitis, epiglottitis, or obstructive. So anything that ends with itis is inflammation because of that bacterial infection. Okay, I'm going to skip that. We already talked about that. Opsonic antibodies and what are the cell components required. Pretty much the same thing, that they have ability to adhere because they have either a pili or they may have non-pilous adhesions that mediate. So because there is a high pressure area in the nose and the lungs where you are continuously breathing in and out. So they have to secure attachment to me. So that's one of the pathogenesis factors that these bacteria have. Okay, we already talked about the clinical summaries. So apart from what I discussed earlier, as you can see in terms of statistics, was a pediatric problem, you can see, but we give you vaccine, pretty much takes care of that. The chancre that I told you can be present on male or female genitalia is still uncommon in the United States, but the rest of the world it's present. But this kind of disease, well, let me put it this way. So Haemophilus ducreyi is the only strain of this particular bacteria that can be sexually transmitted. That's why it is there. Otherwise, most of the infections are caused by patients' oropharyngeal flora. So we call that endogenous infection because this is commonly in your own throat and you get infected, as compared to this one, which you have to acquire from somebody who is suffering from sexual transmissible disease. So patient with the greatest risks, of course, they don't form adequate antibodies to that particular antigen that you gave it to them, or those who depleted complement. That's what when you remember, we talked about complement. So if you don't have a complement, then you have a problem, because complement has to label the, label what? What does complement has to label? What does complement label? Say it again? Complement never labels antigen. That's going to be blunder if you tell them. Complement labels capsule for opsonization. That's what the function is called opsonin. Opsonin means sugarcoat the bacteria by adding to the capsule. Okay, so that's important. Okay, statistics you can see from here. As I said, number of cases reported invasive Haemophilus in person aged less than 55 years from one of, for example, in Minnesota. Every state maintains that. So you can see that before vaccine it was high. With vaccine, it went down, but it again is coming back. And what was the reason of it coming back? I just told you. What was the reason that Haemophilus is coming back? The reason was because I told you that now we have non-typable bacteria. We are giving you the vaccine for type 1b, but the bacteria causing infection is non-typable, so we don't have vaccine for that. That's why the rate has gone up. Make sense? Okay, so look at diagnostic microscopy. You can look at detect either in meningitis case in CSF, or you can culture, as I told you, chocolate agar, but the antigens tests are very specific for H1B. So that's what the most important thing, because the serology means you do A to F, and the B one is the most important. How do you treat it? Of course, you can use broad spectrum cephalosporins, or you can use, of course, active immunization. Why do you want to use a active immunization in this case? Okay, I'm not going to ask you. I'm pretty sure you all kind of drained out. All right, that's fine. The problem is that, I mean, we noticed that, discussed that. I don't know, where do students pick up? They want to be absent 2 days before a test for any particular test. On the day of the test, they are tired, right? And we don't know how to deal with that. But the fact is, as a principle for any, I mean, I don't know about the pharmacy school. I've never been in pharmacy school other than teaching. The rule for the medical student is, no matter how difficult a test you have, never miss a class. If they start missing their class, if you're going to start missing a class for the DASUL exam every Friday, then you will not be in the school. So what will happen is, then we will have to go back and make attendance mandatory, which I have not done so far. So, I mean, as a rule, if you have not studied for the last 3 weeks, call it a day. That's fine. There's always another. You know, there is no last minute rush for you is going to help. It's always advisable as a good study habit. And I know I'm just waiting for one more test 3. And so far, I haven't reported anybody for academic probation, but Naina Richards is on campus, and she's an expert for those of you who are still struggling with how to prepare for exam and, you know, how to do this and that. But of all, it's not a good thing for any class to miss a lecture or a day to prepare for exam which is going to come next day. Okay? All right, so you can see another problem we have in the Time magazine. It's a disease detects tracing the Philly killer. So again, historical perspective, just to have you wake up a little bit. There was a conference taking place for American Legion members. They all became sick, right? 76. It was a big news. They all have severe pneumonia. Death occurred in Philadelphia in a convention, right? So they found out an organism which was not found before. So they call it Legionella because of the Legion conference. The word comes from Legionella. But again, after that, they found out that it was there. And there are tons of other bacteria that are out there that they don't cause problems, so we don't kind of chase them around. But in this case, we did, and we found out that it's important. Legionella Pneumophila, as the word suggests, pneumo means lung, phila means attraction. This bacteria has very specific attraction for the epithelium of the lungs. And copyright pictures, Legionella, you can see from here. And this is how, for example, a good picture, if a dendritic cell or macrophage is going to attach one of the receptors to the bacteria to kind of bring it closer. So sometimes you feel that maybe these receptors don't exist, or they're just cartoon. They are factual, they are there. Okay. So what they did after that, like they normally do, as I said, commensal bacteria yesterday about so many genes and genetic studies, they found out, well, there's not only one Legionella, but there's a very large family. You can see from here, 4 genera. The most common of them is Legionella with 53 species and 3 subs. So you can imagine it's just like crazy word out there. It's difficult task for infectious diseases and hospital patient. For you, I'm pretty sure you're going to struggle with even knowing the basics of Legionella. But when it comes to hospital infectious diseases, they're going to go and care for all the strains, right? Half of these have been implicated in human disease. So it's like 25, 26 of them. But we cannot possibly teach you, but we can tell you so you have an idea what how big the problem is. Legionella pneumophila is the cause of 90% of all infections. And then again, since it has a capsule, they do serotype, and they found out 1 to 6 are most commonly isolated. So this is the stats over here. So if you look at the human disease, for example, so you can see all these diseases. So whosoever walks into the clinic, they will not be happy just to say, hey, Legionella. No, because they have to do serotype. Because they want to relate, for example, in the Legions conference, they wanted to make sure that all of them are suffering from the same problem. And they can locate it up into the ventilatory system of that particular hotel where the meeting was taking place. Because that Legionella was sitting over there and causing infection. So we can go and type it up. So that's how they want to do and relate it to. Gram-negative rods, but you can see from here, they are pleomorphic, the size varies. And then when you, I don't want you to remember the strain, but in the books, they thought arbitrarily silver stain. If you were to stain them in the tissues, right? Because it doesn't really take common strain that we do in terms of gram staining. If you were to do gram staining, they're going to appear like this. You can see from here. Right, so they are pleomorphic, comes in different forms. Some of them are round, some of them are cylindrical, rod-like, different forms. As far as growth are concerned, the most important thing, as I said, you make a chart of all those 4 growth requirements, all those 4 bacteria. We need to have L-cysteine and iron for primary isolation, the very important thing, right? The other important thing is that they are non-fermentative, so they will derive their energy from the metabolism of amino acids, but not carbohydrates. So that's an important thing if you compare it with the growth requirement of any previous bacteria. We talked about the diseases, Legionnaire's disease, right? The Pontiac fever. So these are the 2 most important diseases that Legionella causes. And then again, presentation, you can pretty much see it's like influenza-like presentation as compared to Legionnaire disease, which is a very acute illness. And it starts with the non-productive cough and then involves multi-organ, involves central nervous system and liver. So it kind of goes from a very small pneumonia and progresses very fastly. So that's the clinical picture of Legionella when you say disease Legionella caused by Legionalis. Okay. Now, it is, of course, a intracellular parasite, so that's also important. And in water, for example, if it is, as I told you in that Legion conference, it was in the air conditioning system where you have water, right? Condensation of water or evaporation of water. So it can thrive over there. and it can multiply in amoeba. So you can see it can multiply amoeba, and when it goes into our system, it can go into alveolar macrophages and other cells intracellularly and start dividing there. So that's a typical intracellular parasite in terms of bacteria. I'm going to leave it on you. Pathogenesis, typically the same story that I've been asking over and over again, and none of you respond. So component C3b attached to the receptors, and the other important thing, phagosome fusion, lysosome fusion is inhibited. TH1, TH2, as I said earlier, I will just leave for you to read on your own. Now, as far as epidemiology is concerned, the most important thing that I want you to know, and I'm going to ask you, is that, again, historical perspective, this bacteria is found in the bodies of water, cooling towers, condensers, and water system of the hospitals. Okay, that's important. And it does cause infection, even 10 to 20,000. And patients who are already compromised with their immunity, for example, they are asthmatic, old, sick, and you are a transplant patient, you make them sit in the hospital, and the hospital doesn't have a license, and they don't take care of the cooling tower, for example, then you put them at the risk of this infection. And I already told you Legionnaire's disease, which is going to go cause small pneumonia to all the way to enter into your brain and liver and cause problems. Now, you can see from here, this is the reason that they can survive at very low temperatures. So you can see from here, this is an optimal growth range, 85 degree, right? And they can, if you go for a lower, especially tap water, cooling coils, and other, this can be dormant, and then once you inhale it, then it becomes active. So Legionella sitting over there on those water plants or cooling plants, and then come out and cause problems. Diagnosis, as is routine, microscopy, we do the antigen test, especially serogroup 1. We can also do culture, but again, it needs special media. Seroconversion, what does seroconversion mean? What does seroconversion mean? Okay, no question asked. All right. Then you can do genetic test, nucleic acid I can ask it in the exam. That's fine. Okay. Now, the other tests that are available for Legionella infection is that if you're asked what is the test available for the whole organism, so you have the culture, or you can look at the pathological material, or you look at the gene probes. But if you want to look at the antigen or antibody, you have to use ELISAs and other serological tests that we normally have. As far as treatment is concerned, macrolides for hospital, they have to make sure that they do hyperchlorination. That's what they have to add chlorine to the swimming pools as well, or they use other techniques which are available, right? I'm going to leave this, and I'll just give you 2-3 points for Bordetella, and you can read it on your own. Pretty much the same thing that we already discussed. And some of them are also given some YouTube link that pretty much will give you an idea where is it coming from. But most of the stuff that you will see for these bacteria, especially for pathogenesis, is something that I'm trying to over and overemphasize over and over again in terms of complement, in terms of polysaccharide, in terms of phagosome lysosome fusion. So everything comes back to the basic immunology in terms of infection. Okay, so in this case, for pertussis, for example, so you can see from here, this is a ciliated epithelial cell. It has those receptors, which are glycolipid receptors. And then again, pertussis, especially Bordetella pertussis, is going to inject the toxin over here, right? So it kind of snugly fits over there and cause the damage. And most of the time, this is where the epithelium is denuded of cilium. So if I told you smoking will take your cilia away. So if you have those parts over there, this bacteria will dig down and attach and cause problem. So that's another important thing for us to know, okay? It's present everywhere. But usually children at the younger age are at greater risk, and we get vaccinated for that, right? So we have a vaccine for that. I'm not going to take you the incidence. I think some of you was doing, who's doing body type pertussis as an individual project? Okay, interesting. But you can see from it, even we have vaccine, right? But the incidence is rising. So that gives you another idea in terms of problems that we're having even after the vaccine, because you're not making protective antibodies, or the bacteria is changing, or there's something else going on. But if you look clinically, if a person is suffering from pertussis, you can see it's going to be incubation for 7 to 10 days, catarrhal symptoms, where you see something is coming up, you're unwell, like flu, and then you have a running nose, and then it comes like cough. The typical, the other name for this is called whooping cough. Have you seen somebody having whooping cough? Okay, it's like this kind of feeling. So it's very bad in terms of kids. If you Google that, you will see. I mean, very, very disturbing in terms of drawing blood inside. It's called whooping cough. So that's what you normally see. And then again, in convalescent state, again, the cough is going to go disappear. And then this is a typical pattern for most of the diseases. And many a time you're going to be asked, why is it that incubation period is too long for this particular bacteria? Because it is reaching to that critical mass of bacteria before it causes that infection. So you have to establish that. Okay, we diagnose it, again, the same or important thing. But as far as immunology is concerned, IgG or IgA is used as a confirmatory test. IgG and IgA are two important tests that we normally do for this part. Treatment, the most important treatment is vaccination, DPT. It's very important. One of the most important thing is, and the other important thing is that you give booster doses. You can see from here, that's why you see IgG, right? So 5 doses. So you can imagine this is one of the only, I would say or one of the few infections where you have ages 2 months, 4 months, 6 months, 15 to 8 months, and again come back between 4 to 6 ages. Very, very important, and used to take a big toll on kids' health in terms of having cough. But those who have not had this vaccination, they can also come again and get vaccination at a later time. Okay, and then again, we can use erythromycin for prophylaxis. But if you are there, we normally don't see that in this part of the world. But if you do travel to Asia and Africa, you definitely will see that. Okay, and this is the last slide. Very interesting point in terms of age distribution. I just told you earlier that this is a 1998 red bar and then blue bar. So you can see in 1998 and 2004, the incidence is decreased in terms of children less than 1 year, right? But as you can see from here, now people more than 25 years, they are again showing infection. So I actually remember maybe last year, some of the even pharmacy student told me that she was diagnosed with pertussis, right? And whooping cough, which should be eliminated per se. But again, you can see these are statistics which are based upon the idea that we can still control it to all extent less than 1 year, but more than 25 years age or even 15 years of age is rising. So that shows that either we have to come up with a better vaccine or we have to do something to make sure that you are producing protective antibodies. Okay? So I'll stop here.